we are at the 2-year mark since we began. So welcome to this series. We have a wonderful lineup of speakers, 3 speakers, who my colleague Lauren from the Resilient Cities Network will introduce. But let me just give you some background, some ground rules. That while we may have some people from the media in this session, but please remember that this is not on the record. But if you would like any material, or if you would like to quote some material, please do get in touch with the Resilient Cities Network, and they'll make sure to get back to you. And I would also want you to know that all the material that is going to be presented will be made available online. So you will have access to this material. And with that, let me hand it over to Lauren from the Resilient Cities Network to take us forward. Lauren?
So much, Barjor, and it's very good to see you back on the session with us tonight. It has been 2 years of convening this session together with you, our partners at the World Bank. And I really have to thank you, Barjor, for the work that you did with us very early on when you were still in Beijing at that time to help us connect to professors and city officials on the ground in China when the pandemic started, so that we could hear from them about their experience and bring that experience to our global network. And so we are here tonight to talk about resilient health systems on this 2nd anniversary of this series and going into our 3rd year of living in a time of a pandemic. And during this time, we know that cities and state governments have learned a lot throughout the crisis, and this somewhat repetitive cycle of response and recovery to the different variants, to the different ways that regulations have been implemented over time. So while we're here and the virus is still not considered endemic, communities across the world have been addressing health system crises, gaps, and they've come up with some really interesting innovations that enable us all to live with this virus. And so in this session, we're really going to dive into where cities and state governments are finding themselves 2 years after the WHO declaration of the COVID-19 pandemic. So some of the questions our speakers are going to answer tonight are, how have cities and government entities built their resilience in their health systems? And what are some of the co-benefits we're seeing from this? Are there climate-related shocks and stresses like heats and floods that we can respond to using these innovations? And what are the kinds of partnerships that enable these kinds of innovations? So we're going to hear from 3 very special guests tonight, and I hope you will join me in welcoming them. The first is someone we're welcoming back to the series, and we're so thrilled to have him here with us again, and that is the Secretary of Health and Family Services from the state of Kentucky, the one and only Eric Friedlander. Eric was previously the Chief Resilience Officer for Metro Louisville, and he's been serving as the Secretary of the Kentucky Cabinet for Health and Family Services since 2020, where he leads a $17.5 billion cabinet that is serving every single Kentuckian in some way through its 93 agencies. So we're really delighted to have the breadth and the depth of your experience here tonight, Eric. Next, we're going to hear from Dr. Natacha Berkowitz, who's an epidemiologist for City Health in the city of Cape Town, and she has a passion for urban health and the impact of urban lifestyles on the health of communities. She has an interest in non-communicable and infectious disease comorbidity and integrated care. Her background is in chronic disease care as well as HIV and TB. And at the City of Cape Town, she utilizes a lot of health data to improve service provision through program evaluation and strategic planning. And this was also very critical during the COVID response, which we'll hear more about shortly. And then last but certainly not least, we have the Distinguished Professor of Social and Behavioral Sciences and Professor of Psychology from Yale University, Jeannette Exquivicks, who's with us tonight. And she was the founding director of Social and Behavioral Sciences at Yale School of Public Health and of CARE, which stands for Community Alliance for Researchers and Engagement. And her research investigates the interplay of complex psychological, behavioral, and biomedical factors that influence community health and resilience with vulnerable populations. So a very natural partner for Resilient Cities, and she has authored hundreds of peer-reviewed publications and is an elected member of the Academy of Behavioral Medicine and Research. So thank you all for joining us. It is now my pleasure to turn the screen and the microphone over to Eric to begin the session.
Thank you, Lauren. I'm happy to be here again. Happy to be speaking with my friends in the Resilient Cities Network. And so I want to give a brief kind of description, lay of the land, and then I'll move through. Came to the Cabinet for Health and Family Services a couple of years ago, within months of the pandemic and COVID-19 coming into Kentucky. We started with how we structured the cabinet. Now, for those of you who saw me last time, I talked about it. We came with the idea of making sure that what all these programs do are help folks reach their full human potential. That's our mission. We talked about it then within the context of what we call our pillars or values, and that they have to do with equity, particularly talking about racial and ethnic and rural issues in Kentucky. Kentucky is a very rural state. Of course, one of our values is resilience, which I think is quite appropriate. And we really talked about that within the context of trauma, and that was really an underlying thread for all of the populations we were trying to serve, and that resilience from that was so very important. Didn't realize how impactful and important that would be when we started out. And then this whole concept of economic support and obviously health and family services, health and wellness. These are the pillars on which we're building our programs. So as I said, COVID first was diagnosed, the first diagnosis in Kentucky, not the first case, obviously, was March 6th. And so from that point on, we had to build that response from ground up. We didn't have any kind of supplies of PPE or personal protective equipment. We had no testing capability. You all know that. We had one lab that could do maybe 75 tests. So we really didn't, and very limited knowledge of the impact and what we thought was going to happen. And again, everybody was in that same boat. So we had to respond very quickly, very nimbly. I was very fortunate to work with a public health commissioner who works for the Cabinet for Health and Family Services, who was fantastic, former ER doctor, youngest president of the American Academy of Physicians, period, since I think like the turn of the century. So very fortunate to have somebody like that here. And then we had a governor that believed in science, a leader that believed that we actually should follow the science. So again, that made things ever so much easier. And the focus early, and I think really one of the lessons, the focus early was on communication. And so there were daily press conferences, which were followed by many folks across the Commonwealth, became known as Beers with Bashir at 5. And so folks would tune into that and we'd be able to provide good information. And so through a series of executive orders and things like that, we were able to really start to implement things quickly. You all know at the beginning, everybody was chasing PPE. We had no idea where to get it from. There were lots of scams out there. And so it was just this whole effort to try to determine what was real and what wasn't. And it required a large team and an emergency response, which was used to very narrow responses. Our emergency response teams were used to a flood or a small tornado. And so it was really very geographically centered, not population or state-based as what we experienced. So there was so much learning that had to occur. So those pieces, that communication piece, actually, the governor has just ended the COVID updates. He was on a weekly cycle, but that communication piece again was so vital, and that's with hospitals and nursing facilities and all of the healthcare industry, a level of communication and collaboration that really hadn't been there before. So it's a really strong piece for us that we had to focus on. And then the governor was committed to making sure that we had equitable rollout. We saw and everybody saw across the country and across the world these disproportionate impacts based in Kentucky on race and poverty and ethnicity. So the governor said to me at one point, we have to end all this disproportionate outcomes. This is unacceptable, which was great to hear. But since they had probably grown up over a couple of hundred years, I think it was, I loved the challenge and accepted it. But that was the focus on equity happened early. And so as we got to the point where we had vaccines and strong public health interventions, we did focus on that equity piece. And I think what you'll see as we look over the course of the pandemic in Kentucky, one of the things that I think, focusing on communication still, the communication early was very important. The fact that we were able to do really public health interventions, mask, social distancing, you all know all the terms. The battle became disinformation. And that disinformation was extremely difficult to battle. We have a fairly conservative state here in Kentucky. So that disinformation and protests, and the governor was hung in effigy outside of his own residence. It was really, really difficult to negotiate. We had several court challenges that we went through. And in the end, about a year ago, the General Assembly, our legislative body, really took a lot of the powers away from the governor that he had for public health intervention from the Public Health Commissioner, from the Cabinet for Health and Family Secretary. And you can see the difference. This data-rich environment, which you'll hear more about later from other speakers, you can look at Kentucky's response. And in U.S. states, Kentucky is usually one of the bottom states, bottom 3, bottom 5 in terms of health outcomes. We were really about the middle of the pack, which is great for us because we were able to take those interventions. And if you looked at the states surrounding us in southern states, you can see our response was robust. Once those powers were taken away, and then we had to have a more laissez-faire approach to public health, we regained our normal standing. We were like the third worst, second worst, as we just fell back. So I think there's going to be some very interesting pieces to look at from a data perspective. The other piece of that then is really how we approached equity. We saw the disproportionate outcomes, particularly in death statistics. Obviously, COVID really impacted older folks more, folks in congregate settings. And then you can see the disproportionate outcome related to race and poverty, but particularly race and ethnicity, in part because of jobs, in part because of original health status. So when vaccines became available, the first thing we did was we had a robust group that was looking at equity and equitable rollout of vaccines. We used what was called a social vulnerability index. We made sure that we were targeting and micro-targeting those populations where we knew there were high levels of economic challenges, which always correspond, or almost always, as we found out in our 100 Resilient Cities work, often corresponded with environmental degradation, right? The most environmentally challenged areas were also then the most socially and economically challenged areas. So it was really kind of a very similar focus. If you laid a map out of Kentucky, you would see that we were targeting urban areas, but the rural areas that we were targeting were those that were most impacted by mining and by mountaintop removal and those kinds of things. Same areas, same population. So we really had a very intentional effort on targeting those populations. And you can actually see in the data the difference between kind of by age category, and there's another story to tell here, by age category, prior to the vaccines, you could see the disproportionate impact. After we rolled out the vaccines, and we're very intentional about how we did that, you saw that disproportionate death rate disappear. And so I think the one of the powerful messages that I think I can give here is that kind of intention And that kind of learning that we had in terms of direct outreach, in terms of micro-targeting, it proved to be really effective. So I think that's something that we'll take as a learning out of this. And as I said, the other powerful things that, that direct intention having direct impact, and you can actually make a difference across a state is, I think, an important learning for us. Then, as I said, the communications piece, the collaborations piece, learning how to do that in real time made a tremendous difference across the state. So I think there are pieces that we can take. Now, those of you worldwide, I will say, the U.S. Health system is kind of insane the way it's set up, I will say. So we have a lot to learn from our world partners on how to better work with and have a robust health system. But I believe it pointed up some of the things that we all know about the U.S. system, and that it should be more robust. And we actually use some of the provisions of the Affordable Care Act to extend healthcare coverage out. At one point, we had another 150, 170,000 folks who were temporarily covered by healthcare coverage. So we leveraged some of that. And it, again, seemed to be effective when you look at outcomes. So all of these pieces putting together, I think it's the focus on specific populations, the focus and the importance of communication. I wish we understood how to better fight intentional disinformation. That is, I think, a worldwide challenge. We tried to do that with communication and regular communication. It hopefully had some impact, but again, those challenges, I think we still have a lot to learn. So with that, I think I've taken up most of my time, but I appreciate the opportunity to address everyone here. And again, I believe the data environment, the things that we're going to learn for the next decade over what was effective, what was not, what had actual impact, which interventions worked. I think we're going to learn so much, and I'm actually excited for the next decade for us to learn what was important and what was vital for us to do. So with that, thank you.
Thank you. So may I invite Dr. Berkowitz, please?
Thank you so much, Eric, for that first presentation, and thank you everyone for inviting me today. Just listening to what was just said, it's actually so similar to the story that I'm going to tell from the city of Cape Town. And even though we are two very different settings, it's very interesting to see the similarities in challenges and barriers and enablers to respond to this crisis that affected all of us in very similar and I suppose in very different ways. So starting at the beginning, we had our first case in the city of Cape Town on the 10th of March. And initially, the story that I want to tell is also that story of divide and how the data shows the divide within our communities and how we had to approach the response in two very different ways to try. So I just want to show a quick slide here. So over here, you can see that the transmission originally started in the center of Cape Town. This is quite an affluent, sorry, not going to be seeing a slide just yet. Let me just exit this, sorry. I'm going to just share my screen. There we go. So apologies for that. So this slide here is just showing you the spread of COVID within our community. So initially it started with imported cases. Many people came from overseas, actually skiing in Italy, if I recall. And it spread from our more affluent areas right into our peri-urban, more informal settlements and more socioeconomically deprived areas. And here the final screen you can see is how is the predominance of locally spread cases as compared to imported cases, and this was only mid-May 2020. But if you look and reflect on waves, just to say in a little bit of history about the city of Cape Town and South Africa, is that we have two very segregated healthcare systems. We have a public healthcare system, which is free to use for all, but also a private healthcare system. And obviously the public system is quite stressed. However, in the city and in the Western Cape, the province that I belong to, we have quite a robust system due to our excellent leadership. And the city is involved as a partner of the system by providing primary healthcare and environmental health as well. But in South Africa, we've experienced 4 waves of COVID. Our initial wave being wave 1, where we had very strict lockdowns, is the one in the blue here. And you can see it's quite protracted and quite flat. And that's due to those lockdown measures that we had originally. Wave 2 and wave 3 are the green and the yellow, and you can see they're more severe than the first wave. But this third wave, which was the Delta wave, was huge and protracted, and we really suffered in the healthcare system here. And then finally, wave 4, with the most recent, the Omicron wave, short, sharp, and the least severe. But what I want to focus on is the differences that we experienced in the Western Cape and in the city of Cape Town. And you can see that just in the bottom, we segregate these waves by public and private, so public on your left and private on your right. And you can see the public sector experienced much higher caseloads than the private sector, who was able to lock down and isolate and adhere to all the NPIs that were put in place. And similarly, this is our city of Cape Town divided into 8 sub-districts, which are health sub-districts. And just comparing, if you look to the top left here, the waves in a sub-district such as Khayelitsha, which is an informal settlement on the outskirts of the city, you can see they experienced a very, very severe first wave, and their second and third waves were not as severe. And that was due to the inability to lock down, to isolate, needing to get out into the community, crowded living conditions, and thus developing, some sort of immunity, which resulted in a lower impact of the second and third waves. Whereas if you take your eyes all the way across the slide to either the southern or the western sub-district, which are the more affluent areas, one can see how in the first wave, where they're able to lock down, stay at home, how the differential impact of these within these communities. And now, how did we approach this? It was a whole of city response, really. And what was required was not only the response from the healthcare system, which was providing care, ensuring there was enough capacity for sick patients, building triage centers and mass hospital centers, but it was also incorporating the rest of our departments. And how we did that was through mechanisms that we learned through our drought crisis. So created a COVID crisis committee, which was the CCC, led by the head of corporate services, which pulled in individuals from across the organization, including myself, including disaster management officials, including communication officials, data scientists, policy advisors, and we all work together to create an effective response. And as Eric was saying, how important communication was in our response cannot be diminished. So the way that we worked is that we had ensured that we had experts to advise, and then we had the teams that would go out and do. So we'd send our law enforcement officers out into communities to loud hail, to send out messages. We'd ensure that our enterprise and investment colleagues could put together donations from businesses to reach our communities who were experiencing this the most. We then also, our data science team, and I just want to change my screen quickly, so you should be able to see a map of the city of Cape Town now. we created one of the tools, and one of the data tools that we created was this vulnerability viewer. And I'm just showing you a part of this, but this was basically a map of the city of Cape Town, which utilized various data inputs to provide information to colleagues that were addressing the spread and had to do various activities within the community. So like you said, we had vulnerability indices which we could overlay in the city, and you could see where the most vulnerable individuals were. But not only that, we could identify where people of risk would be, so where our rental stock houses were, or where our old age homes were, so we could easily locate access and create responses. And so this was really a fantastic tool for all the colleagues to utilize. From the health side, what was extremely important was the collaboration between our health officials, and then also we have what's called environmental health or municipal health. And environmental health colleagues are really essential at reaching out into communities. The health promotion, sorry. So I was just wrapping up and just saying how we need to address the naysayers and the misinformation around vaccination. I think my video is gone now, but thank you very much for this opportunity, and I'll hand over to the next speaker.
Thank you so much for the interventions. I think there will be lots more to talk about during the Q&A, but I'll keep us moving here, and let me reintroduce Dr. Jeannette Exquivicks, who will speak to us now from Connecticut.
Good morning and good evening. Thank you, Lauren, and thank you everyone for joining us. I'd like to address two important themes, excuse me, that bridge COVID and urban resilience. The first reiterates and hopefully synthesizes some of what we've already heard from Drs. Friedlander and Berkowitz regarding lessons from the public health sector during this pandemic and actions that can and should be sustained to assure urban resilience now and in the future. And then second, given priorities of the Resilient Cities Network, I'd like to broaden the discourse to address explicitly the links between health, climate, and biodiversity, and the impact they have on cities. And coming from School of Public Health, I'll take this particularly through the lens of prevention. So let me start with health systems. I think it's worth noting that this morning, as I looked on the World Health Organization platform, we are in a situation where more than 450 million COVID cases have been diagnosed, documented, and more than 6 million deaths worldwide. These have been both a shock and a stress to hospitals and health systems, often bringing them to the brink and sometimes over the brink of capacity. Ongoing demands and responsibilities of our frontline health workers are profound. They continue to endure long hours and limited resources, and with their patients face suffering and death. And I guess it's important here again to note that most of these could have been prevented, as Natacha was talking about, with we had very rapid vaccine development, but more sluggish vaccine distribution, and certainly not equitable distribution. In turn, when we look at this collectively, we see anxiety, depression, post-traumatic stress, and burnout among our healthcare workers and public health officials and others, our policy officials. And this pandemic is not over yet. And so we do need to maintain our energy and our focus. So despite the weight of this durable pandemic, there are many things that have been positive and many things that we've learned that we can carry forward to avert the continued serious outcomes of the next pandemic. And I decided to go with a top 10 list in no particular order to seed our conversation during the second half of the hour. First, we must maintain public health and surveillance infrastructure for vaccination, for testing, and for treatment. We need to be able to rapidly mobilize these when needed. Second, we have to guarantee that hospitals and health centers can provide care in safe environments. These include sufficient supplies such as ventilators and medicines, personal protective equipment, and high-efficiency particulate air filters and fresh air exchanges. If our hospitals don't have safe air, then where can we where could we have this? So we need to assume, and we need this to be the first line of defense. Number three, we have to assure that supply chains are diversified and agile. And I think in the spirit of the Resilient Cities Network, this is one place that the public and private sector can and should come together. Number four, prepare for rapid and unexpected increases in service demand. Cities and their hospitals must have detailed emergency plans in place for the influx of patients that are sure to emerge again and again, and we need to assure that there are well-trained staff, that burnout doesn't result in mass exodus from the sector. Number five, sustain and expand telemedicine services where they're available and can be most useful. For example, telehealth has been excellent in mental health, for non-emergency care, and for triaging systems. We can also mobilize technology for connecting providers and patients, as well as connecting patients and providers with family members. And now I'll recognize, of course, that telemed is not available everywhere, but we certainly are at a place globally with a digitized society and cell phones nearly ubiquitous, that we can use these solutions in the healthcare sector. Number six, maintain masks and social distancing, certainly in clinical settings, and also in public settings where large numbers of people continue to congregate and or where people may be vulnerable. I know that the U.S. Centers for Disease Control, the World Health Organization, and others, city and state and country health departments are softening these mandates, but that doesn't mean that those who are vulnerable and also continuing to work with vulnerable populations should not maintain mask mandates and social distancing. We are still seeing surges. This is not done yet. Number seven, explicitly address persistent racial, social, ethnic disparities to reduce stigma, to increase access and quality of culturally competent care, especially for those most vulnerable. Number eight, provide training and support for healthcare workers to cultivate their resilience, always, not just during pandemic crises. Number nine, nurture trust and respect of science, of public health, medicine, as well as our leaders who are elected and selected to serve. As both Drs. Friedlander and Berkowitz mentioned, transparent communication is essential as we think about trust and respect. And finally, we must be prepared to respond to crises while maintaining core functions of other healthcare systems and cities. And this will take multi-sector involvement and collaboration to assure that financial resources are available before the next crisis, and that smart policies are developed, implemented, and evaluated. So that's my top 10. As I said, I hope that I think synchronizes with what you've already heard today. And I'll close in just a few more minutes with this broadened discourse about policy priorities and the intersectionality, recognizing that pandemic risk and the roots of climate change are inextricably tied. And I'll just mention a few ways that this is the case, and we can bring this up again during the discussion if of interest. First of all, deforestation and biodiversity loss impacts animal and insect migrations. And in turn, this has a direct impact on the risk of infectious disease spread. We've seen this with COVID, we've seen this with dengue and Zika, and we see it time and time again. Poor air quality is related both to climate change and to COVID. COVID in particular is a respiratory disease, and of course air quality influences respiratory health. So these links are really quite direct. We have issues of poverty and being an underlying condition, again, that both creates vulnerability to COVID and to climate change. And of course, these are the settings where the most severe consequences then occur. In cities, we have dense urban living, which influences both COVID and climate change. And finally, underlying prevalence of obesity and other chronic diseases, often in cities, also make people, families, and communities most vulnerable to pandemic spread. So in closing, biodiversity, climate, and health are inextricably tied. Climate change is making outbreak of disease more common and more dangerous. And of course, both COVID and the climate crisis disproportionately affect the health of vulnerable and economically disadvantaged individuals and families, institutions, and cities. So I believe that governments must prioritize investment in health and in climate stimulus packages concurrently for synergistic gain. It will take multi-sectoral approaches, government, business, and the health sector, to make these links explicit. One of the founding principles of public health is that these problems are complex. And when they are complex, when the determinants are complex, we need complex solutions. We can't shy away from this. We need to address these health straight on, and we need to do it together to identify solutions, to implement these solutions in a sustainable way to support the health of our individuals and our cities. I will stop there and open it up for our question and answer period in any direction, Lauren and Bashar, that you would like to proceed.
No, thank you. Yeah, thank you very much to all three of you for your presentations. But listening to you, all three of you, what struck me is that this is the Resilience Series network is a network of practitioners, and so what would be of interest to them is to figure out, when you deal with a political structure and communities who do not have the same access to information and data that you have as practitioners, how do you reconcile the conflicting views, and what are the best ways in which you can get them? You can't possibly get everybody to agree, but what are the ways in which you can bring them as close as possible so that you could have an effective response? I'll leave it to any one of you to put your hand up and go.
But I'll jump in quickly and reiterate some of what I think we all mentioned. Surveillance is critically important. You're talking to people, I hope all of us, but certainly among the panel, we believe in data. We must have evidence-based solutions. And so having strong surveillance systems in place and evidence-based approaches that we know can address the vulnerabilities in cities and can strengthen the backbones of our institutions. And so I think that the data, the surveillance, clear communication, and that those all become underpinnings for trust and respect in the system, where we can then begin and sustain these cross-sector communications, where we see that our best approaches are those where we are working together toward shared solutions.
And if I might, the piece of the communication that we've been working on and been very intentional about is we talk about COVID in particular, or any kind of disease as really emphasizing the need of community, and that what we've said is if COVID has shown us or taught us anything, it is that whatever happens to any one of us in a community impacts us all. And we talk about that very directly. The governor has a piece where we have green lights lit for those who have lost their lives across the Commonwealth, and really emphasizing that a virus in particular knows no boundaries, right? And so it can start as in Cape Town in an affluent area, but then spread to a more rural area or a more highly challenged in terms of social vulnerability, and then back. I mean, it doesn't. The gates and fences don't keep things out. So that this is really the message we've been trying to give. I think it's resonated somewhat, but again, the challenge then comes with how to effectively battle that disinformation, and I wish I had an answer for that. I really do.
Yeah, and just to add finally, I think data translation for our politicians is hugely important. I think we made made a mistake in the initial days of the outbreak where we excluded our politicians just due to the intensity of our response. And so including them in the response, and now they are actually our community ambassadors for any intervention that we actually want to drive, and they are the first individuals that take that message out into the community. And repeated surveys on vaccine hesitancy that we've run within South Africa show that if you have political support, the uptake will be far, far greater. And so that's how we've leveraged on our political leadership.
Follow up on that question about creating the right conditions for success. And I think, Barbara, you highlighted capacities and where you might have more or less capacity. I think in all of your remarks in different ways, you talked about very special kinds of teams working together with communications professionals, community health liaisons. I think Natacha used the term environmental health professionals, and the difference between these different kinds of capacities that make an intervention successful. And so my question would be, during the last 2 years, what were the capacity or skill sets that you found to be really necessary to have the right team in place for effective interventions? Because we have a lot of our listeners are coming from different cities, they work in different teams. You know, what advice would you give about the kinds of skills and capacities that need to be built up in order to support these kinds of responses to different health threats going forward?
I'm happy to respond quite briefly, actually. I think those skills are quite variable and dependent on your local context, and can be sought and decided upon based on the response that is needed. Obviously, we are all, as we mentioned in the pre-talk, data nerds, and data skills are essential in this context. But really what I want to emphasize on, and what I experienced, is that solid leadership that can coordinate these various skill sets is really what is essential to a rational response and an effective response, and a leadership that understands how to connect individuals, but also gives them the freedom to respond and utilize those skill sets effectively, is really essential, and what I experienced that worked excellently within the city.
Absolutely. I think that's a tremendous point. We often in the US think of diversity in terms of race and ethnicity, but as you said, diversity in terms of skill sets, so very important. And being able to acknowledge that within teams, and then again, the leadership being so important to be able to recognize when to elevate a team member or when to elevate an issue, and when to intervene when necessary to make sure that those connections are happening across systems. So it's having somebody who can take that leadership role and take that collaborative role and bringing these disparate pieces together, but then also acknowledging that those disparate pieces need to exist, and that you don't need folks who think the same as you. You need folks who think differently, and that is just so vital. So thank you. That was really perfect.
Eric, just as you were coming to the end of your comment a moment ago, I was the term that came to my mind just before you inferred it was groupthink. And I think, this is a place, any place where there is a crisis and such a, dynamic moving parts and huge amounts of responsibility, you for an entire state system, Natacha for, a huge district, a huge city of Cape Town with many challenges. We really need, I come back to very basic, in addition to the hard skills, but this idea of trust and respect being so critical, and cultivating them so that every voice can rise up, and everybody can come to the table with a solution that might seem obvious or perhaps less so, and being open to all of those experiences. Earlier in the hour, too, there was some discussion about local sensitivities and being aware of what's happening on the ground. So we want to be able to, the proverbial think global, act local, the idea that we take the best practices from everywhere, which is something that the network does so well, and think hopefully fairly quickly about how we can implement them on the ground with the leaders and teams in place.
There is one more thing I wanted to say, and actually, Jeannette, you brought it up, but I want to pull it out just a little bit. The other thing about the teams that you have to remember is that your own teams need resilience. And it's one of the things you brought up about the stress of healthcare workers and policymakers, et cetera, et cetera. You also have to focus on their resilience. And I brought up trauma, and what I meant by that also was secondary trauma. And that is the trauma that the folks who are working through this, right, who've never seen this before, or the folks who are trying to go into communities and provide good information, that we pay attention to the shocks and stresses that they are feeling, and being able to provide that support for, yes, you need, in the midst of this, you need to take care of yourself as well, or else you will not be able to continue to function as a team member or as a team unless you're able to provide for your own personal resilience. And that's something that we tried to make sure that we were doing throughout this process with more or less success. But it's so important to at least be able to acknowledge that, to have a functioning team long term.
There's an interesting observation from Duncan from Glasgow, and it's actually slightly off, slightly takes us into a slightly different direction. Is that what is the role of city level facilities like green spaces? But when you want to have these lockdowns, what do these city level facilities? What's their role, and how much of attention should we pay to them?
I can just add to that. I think Duncan brings up an interesting point, which is about the co-benefits for climate. And I think that it would be really interesting to hear from this group some of the co-benefits that have been measured, both on the health side and perhaps what you are seeing going forward in terms of climate resilience as well.
So one of the pieces, and maybe this is where we're going, when we were talking about lockdowns, the ability to have green space, and we have state parks and things like that here, the ability to have green space and for folks to be able to leave their homes and be able to walk outside, and that impact, and really that was a direction that we gave. We were saying your opportunity to experience and get out of the isolation, but to be in that public space safely, right? What really, we saw this big uptake in use of our public spaces as we went through the pandemic. So having those was critically important. And when you don't have that kind of the public health benefit of all that, having walkable space, having space where you can gather outside, we knew that it was important, but being able to have that opportunity for folks was critical throughout this. And again, as I mentioned, I think as was pointed out in the data from Cape Town, the same places that have environmental challenges were also normally high on the SVI. And so really being able to address that from the perspective of green space, from that resilient space that we tried to put in our cities, was absolutely critical in terms of how we address how we addressed COVID as well.
And I'll just carry that briefly forward and say, here is an extraordinary opportunity to sustain those important resources. We recognize, I can't imagine there's not a single one of us on this call who, I hope, who did not take advantage and recognize the importance of green space, particularly in the early days, but again, still as we persist. And I hope that this is an area where we see these ties quite directly and where we mobilize the political will and the financial will to sustain those green spaces. In the chat, Eric, you are also responding. I didn't see the question, but I saw a response around behavioral health and addiction. And being in nature is great for our physical health. It's great for our mental health. It's great for connectivity with others and a safe space to be with others to reduce isolation. So I hope that these are resources that we can sustain moving forward, and that we, if there's making lemonade from lemons, that one of the outcomes of the COVID pandemic are cities with stronger green infrastructures.
In one of the effects from this, from more people utilizing our green spaces in Cape Town, was that they became safer. And so the more people that use them, the safer they become, and you get that cycle of usage. And then also, not only that, but it increased the constituency of people that used our green spaces. So we have a beautiful park in the center of our city, national park. And usually it was the more affluent individuals that lived around the mountain that really used it. And from the different lockdowns, we saw a much greater mix of socioeconomic classes using these spaces. And it creates ownership of these spaces across the community, which, you can't just have a very small pocket of the community wanting to support these essential spaces. And so once you create ownership across the divide, you ensure continuity of protection of the space, which obviously has knock-on effects for climate, et cetera, et cetera.
And I think that's beautiful. I love that. I think we'd be remiss not to say a couple of other things. Clearly, the environmental degradation and the encroachment of urban areas on more rural areas or wild areas, we are going to see, or the fear is we are going to see more of these global pandemics, not just every 100 years, but probably like we're seeing in floods and things like that. The 500 years floods occurring every 20. We are going to see more of this if we do not address that globally. In Kentucky, we had in December, which is rare for us, this tornado that tore across the western part of the state. The tornado was on the ground over 250 miles. And so that emergency response was informed by our emergency response to COVID, but that kind of impact of a tornado and its path and its intensity that we had never seen before. Clearly, these kinds of emergencies that we're responding to will unfortunately only become more frequent.
Thank you for those responses. I think you've given us so much to consider this evening about how we respond effectively when the challenges are numerous, even if there's a single threat that's coming at us, how that manifests in different locations can be very different. I think you've all shared with us some very deep experiences from each of your places. We have only a couple of minutes left, and I wonder if you would all like to share just one takeaway message with our audience before we wrap up. I would come first, perhaps, to Jeannette. I see you smiling. And then we'll come back to you, Eric, and then we'll come to you, Natacha.
Thank you, Lauren, and thank you, everybody, for the opportunity. I guess I would close out and talk about how important it is that cities remain prepared for this ongoing, this durable pandemic, and looking ahead to the future. I think that collective responsibility and systemic response are important. They are more complicated, but we have risen to the challenge in this regard. And I believe that this collective systemic response is what will lead us to durable action, and one with a focus on prevention.
Resilience. How we foster and what we were doing in the Resilient Cities Network is so critical as we focus on community resilience, individual resilience. Those lessons about what helps us come back from those shocks and chronic stresses, which were chronic stresses we're going to experience, that's critical for us and critical for us to look to and work on. So I'm thankful I was a CRO because that resilience is probably the most important thing that we can focus on.
I get the last words. I think I'm just going to build on what my colleagues have said. And for me, it's the collaborative engagement within whichever organization or team that you are working with to respond, but also ensuring that you do not forget that part of your team is the community that you're serving as well. And it's essential that they are part of whatever you are planning and part of that essential resilience response as well. I'm going to leave it at that.
Thank you so much to each of you, really, for sharing your wisdom with us this evening. It's been a really wonderful session. I wouldn't say to celebrate, but certainly to recognize this 2-year marker. Thank you for being with us and with our community here of practitioners, because this is how we support each other. So thank you again. With that, I'm going to bring us to a close. I want to remind everyone that we are back here in 2 weeks' time with another series. This time, the timing is going to be slightly different. It is going to be a session on aligning infrastructure for resilience, and it will be specially timed to be in the morning here in Asia Pacific. It will be at 9 a.m. in Singapore. By then, the time zones in parts of North America will change, so it will be 9 p.m. on the East Coast. We hope that we'll see many of you back here live for that session. And again, on behalf of Resilient Cities Network, on behalf of the World Bank, we want to thank you all for being here with us tonight. Good night.
Thank you.
Thank you. Goodbye, everyone.